Welcome, Professor Guillermo De Velasco. You are from Madrid University Hospital, and you are a very well-known figure in the management of renal cell carcinomas and all kidney cancers. And probably first time you are visiting Kerala, and so how do you find our place? Kerala.
Well, so obviously, first of all, thank you so much for the invitation. It's a real pleasure to be here. And yes, that's my first time in Kerala. And I'm really, to be honest, really impressed with the hospital. So, when you come here and you see that it's like such a huge hospital for cancer center, 300 beds, honestly, coming from a more global hospital, because we attend any kind of, not only tumor, but anything else, it's quite impressive to see 300 beds dedicated to cancer. Like, it's quite amazing. And just been talking a little bit about the numbers, and it's again really impressive with the such a huge volume of tumors that you see here. It's really quite impressive for me.
So it's a tertiary cancer center here. So probably we are getting all the cases referred here for the treatment. But still we see steady increasing in the number of kidney cancers. Here the figures are going up. But fortunately, there's a lot of developments are taking place in the field of kidney cancer. So I'm sure you are being part of the recent ESMO guidelines and working only on the management of kidney cancers. So what do you think the kidney cancers in the next 10 years will we be able to conquer or cure kidney cancers?
So I guess when we are thinking about kidney cancer, we need to be, at least very happy about how things have moved in the last 10 years. So I think there have been like amazing changes in the management of metastatic RCC. Basically, with the immunotherapy, we are seeing now patients living longer and longer. That's amazing. For many patients that I do not consider them to be cured by the time being, but at least it's a really long, durable remission in CR. That's amazing. Also, we've seen the adjuvant pembrolizumab. Yeah. So it's also moving. Like, the immunotherapy has really transformed the kidney cancer. But I think this is not over. There are still many patients who really need better treatments. We are over-treating some patients in the adjuvant setting. So I think still for the next 10 years, we need to do better classification. So to make sure that we are not over-treating some patients. And obviously, the other way around, we don't need to skip some treatments that may benefit. So I think there are triplets coming. So we are using doublets now. So maybe triplets will be the next step in the near future.
What about the quality of these patients? Are we really looking into the quality of these patients when we are pushing them or the immunotherapy and all the latest tyrosine kinase inhibitors? So are we really looking into the quality of life of these patients also?
Yeah, so I guess as medical oncologists, our first step is try to improve the OS. We want to improve, we want to make sure that the patients are living longer. Yeah. But because we have better drugs now, and we are able already to improve the OS, the overall survival, we are trying also to improve the quality of life. So now, if you look at any phase 3 clinical trial with new data, it's always showing what's the quality of life. It's not the primary endpoint, but it's coming along.
Still, yeah. Our first aim is to push the survival of these patients.
Yes.
And then, of course, the quality of care, quality of life is also very important. Yes. And that will follow the survival.
So basically, we need to make sure that we are improving the overall survival with a good quality of life. Excellent. That's definitely a must in our work.
So these again, as we were discussing about the cost of treatment, because I told you the 75% of our population are spending from their pocket, not by the insurance. So as a medical oncologist treating these kind of cancers, I am really worried about the hike in the cost of treatment, and it's very severe financial toxicity. I will say it's financial toxicity. So what do you think, whether we will be able to reduce the cost of treatment in future?
So what I guess one of those, so usually, the development of these drugs are really expensive though. you know. So somehow I understand that the prices of the immunotherapy or any other treatments may be really expensive. Obviously, at some point we need to find something in the middle. You know, we need to make sure that the most patients get more benefit. And I think it's also something that it's probably not in our hands as medical oncologists, but it's more about the authorities. Then they need to make sure that they get the pathway so more patients can get these kind of treatments. That's the first thing. And obviously, one of the important things is that we were talking at the beginning about long durable remission. Yeah. So obviously the cost of some drugs is really bad because you spend a lot of money just to improve a couple of months. That's definitely not worthy. But in these situations, especially with immunotherapy and kidney cancer, is kind of the paradigm where obviously even a high investment, it may be really, really good for everyone, for the patient, but also for the society, because there is one patient that has been somehow cured and it's back in the society to help whatever he was doing before.
Yeah, true. And when more number of patients can take this kind of treatment, then naturally the cost will come down.
Exactly.
It is generalized and getting generalized. But at least there is a hope for these patients. 10 years back, we never used to talk about treating kidney cancer beyond 8 months or 1 year, because their fate is almost decided. But now, with anybody who comes with even stage 4 kidney cancer, we can tell them that don't worry, we have enough treatments. There are different types of treatments are coming in the future also. So their future is going to be bright, right?
Yes, absolutely. And you were saying something very relevant. It's like we have data now of trials 90 months follow-up.
Correct.
90 months follow-up, it's amazing. Like you can see the 1 out of 4 patients with these combinations have not progressed after 90 months. That's amazing, definitely. And also, as you were saying, things are moving so fast. Like if you treat somebody today with one treatment and you control the disease not forever, but for a couple or 2 or 3 years, in 2-3 years, the landscape may be changing again because there are many trials ongoing that may potentially will be changing as well how we treat patients in the future.
Correct. So I'm so happy that you have taken pains and to come out to Kerala, and now we are going to have an interaction with all our doctors here. So that will ultimately lead to the benefit of our patients in terms of management, and whatever the research has brought out in the recent years. We are going to discuss all these things with our team here. And finally, I hope that all patients in Kerala as well as in India will be benefited by your visit. Thank you so much for joining us today. And I wish you all the very best in the future endeavor.
Thank you so much, and thank you for having me here.